Good morning. Today we are going to have another session of webinar conducted by East West Pharma. This is special because we have a foreign speaker with us today. He will be talking on epidermolysis bullosa. Now, Dr. Ravi was working in Bangalore as pediatric dermatologist, and he had done some original work in pediatric dermatology, and then migrated to US, and he is now in University of Alabama, where he is assistant professor entirely looking after the pediatric population of Alabama. And he has organized a number of pediatric dermatology workshops in Alabama, and he himself invites you to be part of the pediatric dermatology programs conducted by him. And if anybody is interested, they can directly contact Dr. Ravi, and he will be very glad to facilitate your entry into US and get a training in his institute. Regarding Dr. Ravi is very well into pediatric dermatology while he was in India, and he had a lot of presentations in India at various fora. Now, and his special interest is in epidermolysis bullosa. He had conducted many awareness programs as well as teaching of care of epidermolysis bullosa patients, because epidermolysis bullosa, as you know, it is not a curable disease. However, with the optimal care, the longevity and the quality of life of epidermolysis bullosa patient will be much better. Anyway, epidermolysis bullosa, as for the Indian dermatology trainees, is important in a few aspects. One is it is a stock question for university examinations. Second is once in a while you will get an epidermolysis bullosa, and you may be perplexed what to do with these patients. And if you are giving a very structured approach of management, the burden of disease will come down to a great extent. So you have to study epidermolysis bullosa for yourself to pass the examination, and for the patients whom they come to you for treatment. So over to you, Dr. Ravi.
Thank you, sir. And I'm not a foreign speaker, I'm still an Indian. Thank you, the organizers from East West Pharma, for having me address the postgraduates on this very different topic, which I feel has a lot of science in it and also humanity. I will try to be a little more interactive and see if and help you all understand the disease and what we have done, because much of my work, although I am right now in the US, much of the work has been done in Bangalore itself. In fact, almost all of the work. I would say. And let me share my screen. Can y'all see?
Yes, doctor.
Okay, thank you. I have titled it as Approach to Genodermatosis from Bench to Clinic, but then I'll be focusing mostly on Epidermolysis bullosa itself as a prototype. And I should have mentioned that, but I don't have any conflicts to declare. So what I'm going to do is I'm going to highlight EB as a model and also help you understand how advances in molecular biology can help in understanding the disease. And two, we'll understand some of the common subtypes of EB through case studies. What are their clinical manifestations and what it means to the patient. And three, we'll understand how to organize a multidisciplinary clinic, because many of these patients, not only EB, there are other number of other dermatological disorders in which you need a team of doctors to help or manage the patient rather than just the dermatologist. And then I'll also make a mention and talk a little bit. I may not have pictures, but then a little bit on the FDA approved therapies, which have just been approved in this past 1 year. Definition wise, it is a heterogeneous group of mechanobullous disorders, which is inherited, and it is characterized by blistering of the skin and the mucous membranes, either trauma-induced or can be spontaneous. There are 4 major types of EB: simplex, junctional, dystrophic, and mixed or Kindler EB, they call it. Now, if you go how this classification is done, it's based on this structure of the dermoepidermal junction. I'm sure you're already aware of the dermoepidermal junction. All of you are in your final year or different years? Anybody? Typically,
They are in different.
okay. Okay, but they have at least spent 6 months in dermatology.
Yeah.
Okay. So you're well aware of this structure of the dermoepidermal junction. This is a very, very simple cartoon which shows, the level, this is the basement membrane zone, and anything above the lamina densa, you have a more, it's either simplex and partly junctional, and anything below the sublamina densa, that's the sublamina densa, that is where the anchoring fibrils are, is the dystrophic. And if you have a mixture of all of these, that's the mixed type, which you see in Kindler EB. It's a little more detailed picture of the dermoepidermal junction, where you have a number of proteins which are components of the dermoepidermal junction. So mutation in any one of these proteins can result in epidermolysis bullosa. That's why even though it is a single gene disease, but it is caused by multiple genes. So in a given patient, it is just one gene, but EB itself can be a result of multiple genes that can be involved, or eventually the proteins. For example, now simplex, it is keratin 5 and 14, and then you have the Kelch-like family, then the exophilin, plakophilins, desmoplakin, plakoglobin. These are all the proteins which can be mutated in simplex. Whereas in junctional, it is largely laminin 332. Yeah, here it is. This is the laminin 332. And then special types of junctional can be involved with integrins alpha 6 and beta 4, where you get pyloric atresia. And plectin presents both as simplex and junctional forms, where you get skin involvement with laryngeal involvement and muscular dystrophy. Then, of course, you have the most important structure here, which is the anchoring fibrils, and that is made of collagen 7. And this is the most important protein which is mutated in dystrophic EB. So in simplex, you have the more superficial genes. In junctional, you have the one in the hemidesmosomes and the lamina lucida, sorry, not the hemidesmosomes. And then you have in dystrophic, you have sublamina densa. This is the densa, so sublamina densa, where you have collagen 7. So largely you have three different. So the type of EB, the classification is based primarily on this, although they have modified this several times. And this is the most recent classification where they compare it with an onion, like how you peel the onion one layer by layer. You try to have different parameters to define the single patient and then classify that patient in the specific type of EB. So it starts with the major clinical subtype, and then you have that's the phenotype, which is based out of the severity and the distribution. So you have EB simplex, which could be generalized or localized. And then you have mode of transmission, which could be autosomal dominant or autosomal recessive. Then you have the ultrastructural site of cleavage. So this is at the basement membrane zone. And then the protein. So here you can tell that the involvement is laminin, the beta subunit of the laminin 332 or collagen 7 or keratin 5 or 14. And that's how then you describe the specific mutation. So this classifies a given patient to a specific subtype of EB. This is a more working classification, which helps in prognosis and also management. Now, why do we need to learn EB? Yes, as Sir said, that, of course, you will be asked questions. That's a different thing. But this is a very rare disease. But still, you need to understand, because these patients also have the right to live, and their quality of life as important as any other patients. Now, in the existing scenario, this is the map of India, which is not new to any of us. What I would like you to know is this large land area with different, climatic conditions, a very heterogeneous population. And most of our healthcare is state funded, that is based on government hospitals, because many of these patients cannot afford to go to private hospitals. But the funding is very limited for rare diseases. And then private sector, as I said, the costs are very high. And people don't invest in these conditions because they are very rare. So this is the existing scenario that we have in India. Now, before we delve into what we can do to these patients, we'll understand the clinical manifestations. And here is a case study of a 3-year-old boy who presented with generalized blistering since birth, spontaneous and trauma-induced. Lesions healed without scarring, and there was history of similar lesions around the mouth. There was a history of difficulty in feeding. Lesions were localized to the hands, especially the fingers, and once they started school, the ankles. Otherwise, a healthy child with normal milestones and growth. Born to non-consanguineous parents, and there was no family history of similar complaints. On exam, there was clear and hemorrhagic bullae, tense and flaccid. Face, the areas were pretty much generalized, although on the extremities, it was localized to the bony areas or the trauma-prone areas. There was also post-inflammatory hypopigmentation and hyperpigmentation. The nails, teeth, hair were normal. Mucosa also was normal. Slowly, on follow-up, we could see that he started developing focal palmoplantar keratoderma. You can see the picture over here. You see there is post-inflammatory hyper and hypopigmentation. There are some hemorrhagic blisters, involvement of the hands. The nails are intact. Obviously, you can't see the mucosa, but the hair and the mucosa were normal. And this is the pedigree of the patient where there is no family history. Now, this pedigree corresponds to an autosomal dominant condition. Now, you would expect family history in autosomal dominant conditions. Yes, that's right, but not always. You can have a sporadic case of an autosomal dominant inheritance, and that is because of de novo mutations in the embryonal stage. Now, what we do is, how do we confirm the diagnosis of EB here? So we do a skin biopsy and immunofluorescence. A regular H&E has no role in the diagnosis. So it really doesn't show anything apart from a blister or some raw areas. On immunofluorescence mapping, here again, I'd like you to understand that these are not the regular monoclonal antibodies that you use for autoimmune blistering disorders. For autoimmune blistering disorders, you will use IgG, IgM, C3, and IgA. Whereas in EB, you will use keratin 5 as 14, collagen 7, laminin 332, and collagen 4. Now, collagen 4, if you look at I'll go back to the previous slides. If you look at this slide, collagen 4 corresponds to the lamina densa. So that delineates the level of split. So if you find a blister above the collagen 4 staining, that means it is something more superficial. Or in other words, it's either simplex or junctional. Whereas a blister below the lamina densa or the staining of collagen 4, if that staining of collagen 4 happens to come into the roof of the blister, that means the blister is below the staining. That indicates that it could be a dystrophic EB. So that helps us in delineating the type of EB there itself. Now, specific proteins we use because these are the most common proteins that are mutated in our population. Although special types are present, like as I said, plectin, laminin, integrins alpha 6 and beta 4, and then you have plakophilins, the desmoplakins. Those require specific monoclonal antibodies to be used for staining. But broadly, if you look at these 4 antibodies, you can fit a given patient into one of the major subtypes of EB in more than 95 to 99% of cases. So as keratin 14, here if you see, this is the normal keratin 14 staining, and here you see some clumping which goes on in the epidermis. That tells you that this protein has been mutated, whereas collagen 7 and laminin 332 are normal. So that means this patient has clinical findings suggestive of EB simplex, has skin biopsy immunofluorescence findings suggestive of EB simplex. So when you do a genetic testing, what did we see? We saw mutations in keratin 14, and in fact, this patient had a single nucleotide change, that is G to A. This is basically tells you that this is a missense mutation. So from arginine, it is changing on to histidine. That is what is happening in this. Because of this mutation, the protein is being abruptly, it is undergoing, there is some protein being formed, but not completely. And that protein shows these kind of abnormalities. So if you see the wild type and the mutant type, there is a change in the PI. and the molecular weight, which in turn results in the clumping that you saw in the immunofluorescence. Because of clumping, that means the integrity of the epidermis is lost. So that results in trauma-prone blisters. So that's how you're seeing blistering in this particular child. Now, because this is involving keratin 14 and not the sublamina densa, that means where the anchoring fibrils are, you don't see scarring. You don't see involvement of the mucosal membranes, but you see involvement of the skin of the body. It could be generalized or localized. And you could also see certain type of features called palmoplantar keratoderma, which is typically seen in EB simplex generalized severe forms. In fact, this is one of the hot spot mutations, common mutations that you see in what was previously called as Dowling-Meara type of EB simplex. Now, what does this mean to the patient? So as I said, this patient has EB simplex, generalized, severe. It is autosomal dominant because it was heterozygous there. If you saw, the pedigree also was autosomal dominant. And when you saw the mutation, it was heterozygous. That means one copy is enough to cause the disease. And that happens in autosomal dominant conditions. And what is the protein affected? Keratin 14. And what is the type of mutation? Which is a missense mutations. And this is, as I said, it is the most common mutation that is seen in Dowling-Meara. And parents do not carry the mutation, which means that the chance of this recurring in the next pregnancy is very, very, very rare. But if this child grows up and has his own child, then there is a 50% chance of that child having the disease. Okay. This is what it means to the patient. I'll show you another example of a 3-month-old female, blisters since birth, spontaneous, no feeding difficulty, but has pain while cleansing and passing stools and urine. Born to 2nd-degree consanguineous parents, but there was no family history of similar problems. Lesions healed, but without scarring or melia. There, on examination, there were large crusted erosions on the elbows, buttocks, lower back, and there was nail sloughing also with subungual hyperkeratosis. You will see these. You see the nail involvement over here and large erosions, and in a newborn with history of consanguinity. That is very critical. And when you do the skin biopsy, you see this is the normal skin. The keratin 14 is normal. Collagen 7 is also normal. Collagen 4 tells you that the split is, this is the blister here. So the split is above. So that means it is something either simplex or junctional. If there was simplex, it should have affected keratin 14 or 5, but that is normal. Whereas if you look at laminin 332 staining, it is completely absent over here, whereas present in this normal control skin. You always use a normal control skin to compare. So that means this, what you are dealing with is a defect in laminin 332. It could be the alpha, beta, or the gamma subunit. There are 3 subunits in laminin 332. Now, based on, now we need to check and see which is the protein that is exactly mutated. So we did the genetic analysis by using sequencing. And by that, we found that there is a homozygous substitution of G to A. And what does this result? This results in a stop codon. That means this is a nonsense mutation. So when the DNA is being read all along, or when the protein is being formed all along during the transcription process, or the translation first and then the transcription process, when it comes to this location, it does not know what to do. So that means it results in stoppage. It results in a stop codon, resulting in either absent protein or no, or very, very little or abnormal protein. And that is seen in turn as absent laminin 332 staining, which you saw on the skin biopsy. And because laminin 332 is a very, very critical protein for life, most of the time, this particular condition is fatal. This was previously called as Hurlich's type of junctional EB. And there are non-Hurlich's forms which are not fatal. They are less severe, but not as simple or not as mild as simplex. So what does this mean to the patient? Again, here you see that this was homozygous. That means this is being autosomal recessive. Both the parents are carriers. So that means there is a 25% chance of the next pregnancy being affected by the same condition. That is something which we need to counsel the family. Okay. And in fact, that's probably one of the first things that you would do to when you encounter a patient with EB, counseling and wound care. We'll come to that a little later. So clinical significance here is wound care and supportive management and prenatal diagnosis, because most of these cases are fatal. So couple want to have a normal pregnancy and a normal child. So prenatals becomes very, very significant. Now, the third condition type of EB is highlighted in this case. A 1-month-old male baby, blister since birth, again spontaneous and trauma-induced, born to second-degree consanguineous parents, no family history again, generalized flaccid bullous. So if you look at it, it pretty much is similar to the previous case scenario, right? And that's what it is in the neonatal age groups. I'll show you the pictures also. Oral involvement is present in this case. There was some dystrophic nails. Of course, patient died in this case, although there are forms where they don't. I'll show you that. Now, this is the picture. You see there is large erosions, and you see the nails can be affected. There is some sloughing, but not as much as the previous case. This is how they present in the neonate. So if you get a patient in from the NICU and you see this kind of a scenario, it becomes difficult to pinpoint and tell whether this is dystrophic, junctional, or simplex. That is the importance of doing counseling and getting the diagnosis in these patients early in life. So what we do for diagnosis, the simplest is immunofluorescence mapping on a skin biopsy specimen, and of course, genetic sequencing. Okay, that is the confirmatory diagnosis. But before that, you need to counsel the family and let them be aware of the fact that this can be potentially fatal, because and also explain what it means to the child and to them. Now, the same child, if we look at the biopsy, you see this is normal collagen 7 on the control skin, whereas it's completely absent here. This is the blister. B is the blister. There is no collagen 7 here. Whereas collagen 4 is, it's showing this is the collagen 4 staining, and this is the bulla. So that means this is below the collagen 4. That means the collagen 4 stains to the roof of the blister. So that means the blister is something below, that is situated in the anchoring fibrils or sublamina densa cleavage. And that is classically seen in dystrophic EB, which is largely because of mutations in collagen 7. And as seen in this child, when we did the sequencing, this was a homozygous frame shift mutation. That means there was a deletion of C and T, and that resulted in a complete frame shift. That means the open reading frame is the mRNA which is used to translate into a protein, and that completely changes. And so it results in either a defective protein, or it results in no protein at all. So even if there is some amount of protein that is synthesized, what happens is it undergoes what is called as nonsense-mediated decay. That means the protein gets destroyed by the tissues, and so it's essentially behaving as if there was no protein at all, which is what you saw when you did the skin biopsy, showing absent collagen 7 staining. And because of that, you end up with scarring. And so that's exactly what it means to the patient. So this is a dystrophic EB, generalized, severe form because of the mutations and the presentation. It is autosomal recessive because this is seen in a homozygous pattern with a family history of consanguinity, and so that means the recurrence in the next pregnancy is 25%. This is also called as RDEB, or recessive dystrophic EB, generalized intermediate. That's because of the mutations that are present. However, in our case, it was fatal, so I wouldn't be wrong if you called it generalized severe. Now, not all cases can be fatal. There is significant morbidity in terms of prolonged wound healing, systemic complications, and the occurrence of squamous cell carcinoma. You should note that EB is one of the conditions where there is an extremely high risk of developing squamous cell carcinoma, much more than even xeroderma pigmentosa. Now, when I see the pictures, you see how this is in the neonatal period. This is how it presents in later childhood. You see the scarring, the atrophy, and you see the mitten hand deformities. This is all the cause for extensive morbidity. This is what happens to dystrophic EB patients. And so much of the work is directed towards these cases. Now, what do we learn from these three cases? As this is something which is repetitive, I don't want to go in through this too much, but what is important is early diagnosis is important because of case fatality. Now, we learned about how they present. Now, we need to know what we can do to them, because that is the only thing which is in our hands. Yes, we can tell them that this has no cure, but that's not the end. They do have certain issues that can be tackled. For example, they'll have recurrent blisters and chronic wounds, particularly in dystrophic. Again, pain resulting from wounds, more in dystrophic, sometimes even in junctional. Nutritional, all of these are more in dystrophic, but can also be seen in simplex. Especially the psychological support, financial burden is in all the different types of EB. Again, now, lack of awareness, limited resources, I had mentioned earlier, long distances to travel to access care. This confounds the problem. So we used a four-pronged approach with patient care as the single most important thing. Then, of course, training people, then research, and social responsibility. I'll highlight mainly on patient care and social responsibility. Now, what we did was, to seek referrals, we needed a platform. We have a link which we used to send it out to various dermatologists across the state and also the pediatrician. The focus, as I said, was on diagnosis of subtype because they have different prognostic implications. And then we enroll them into a registry. So thereby we get an idea of what is the problem in our population. And of course, it doesn't end with that. The step, what is more important, is in treating them. Now, how do we treat them? The main areas of focus are wound care, extracutaneous manifestations, then interventions, and follow-up. All of them are equally important. Now, this cannot be done by an individual alone. You need a team, a multidisciplinary team. Now, how do we organize the multidisciplinary team? Usually these clinics are about once every 3 or 4 months, about 4 or 5 patients you can have per clinic. In fact, Dr. Divya Gupta and Dr. Manoj are organizing an EB clinic at Center for Human Genetics this coming Monday, not tomorrow, but the Monday after that. That's on 23rd. So if anybody is in Bangalore on this, are welcome to attend or write to me. We will give you the details. So the team consists of a pediatrician, a dermatologist, a nutritionist, because there are some issues. This is the basic, and of course, a dentist, an anesthetist, and a nurse. An anesthetist, a physical therapist, social worker, gastroenterologist, ophthalmologist, plastic surgeon, all based on the need. So what we do is we do a needs assessment, or a problem sheet is created by the clinic nurse who coordinates the clinic. And then we call each of the specialists on that one particular day. So it's like all in one clinic. So the patient gets to see different doctors at the same time. Okay. Now what they do is they examine the patient individually. They write down all their findings and their recommendations, and they are discussed as a team in front of the patient. And then the nurse makes the recommendation and summarizes them and hands it over to the patient. And in fact, we send them back to the referring either dermatologist or the pediatrician, who can take care of them in their local surroundings. Now, this all prior to the pandemic happened in person. But after the pandemic, we started using telehealth platform with an app which we called as EB-CARP, Epidermolysis Bullosa Care and Registry Program app. And that was being used for purpose of doing this multidisciplinary clinics, which was quite popular. Now, this is how we organize the clinic and role of each person. Each person has their own role. Dermatologist, as a dermatologist, what we focus on is skincare, avoidance of trauma, management of blisters, and wound management. Now, pain management, again, is a separately different topic. I don't want to talk too much on that. Wound care management, most important is reducing friction and avoidance of blisters. That is very, very difficult in a child because you cannot possibly hold a child still. So what we do is we dress that wound, we create cushioning effect so that the wounds don't happen repeatedly on these areas. Now, one problem with that is our country is a tropical country, and we do not have thermally regulated environments. So heat itself induces trauma. So many a time I found that patients were not using the dressings, which are specialized dressings here, because that was inducing more trauma, or rather blisters. Now, these dressings are very specialized dressings because they should not stick to the skin. It should stick to the wound, but not to the surrounding skin. So when you remove the dressing, it should not peel off the normal skin. That's the idea of using these specialized dressings. Some of the common names for that is Mepilex or Mepitil, Argotul. These are the common dressings which are used. Mepilex is more like a foam-based dressing. Mepitil is more like your Vaseline gauze. But the most characteristic feature of these is that they are non-adherent. Along with this, adequate nutrition is important because wound healing improves only if there is adequate nutrition. So that brings in the role of a nutritionist or a dietitian. And of course, sometimes you might need to do a gastrostomy because nutrition, especially in dystrophic EB, where there is esophageal involvement or poor feeding, feeding through the G tube, a gastrostomy tube, helps in bringing in adequate nutrition to the child and thereby improving wound healing. And what we found, an interesting fact that we found in our population was many of the dystrophic patients, or rather some of the dystrophic patients, develop what is called as uh, um, limbal stem cell deficiency. And that started happening, showing up very early in life, like as early as 6 months to a year. So that's when I started bringing in the ophthalmologist much earlier in the care rather than later on. Yeah, I'll show you some pictures of that. And these are again, I showed you pictures of the mitten hand deformity, and that is corrected by the plastic surgeon. And when each of these, if a patient has to undergo a procedure, the second advantage of doing the clinic is to understand the need for interventions. Now, some patients may need only wound care, some patients may need a gastrostomy, some patients might need a gastrostomy and a corrective hand surgery. So multiple procedures may be necessary. So what we do is we sit with the team and plan multiple procedures under one anesthesia. Like how we had all in one clinic, similarly, you have all under one anesthesia. So multiple procedures done under one anesthesia. So this is the advantage of having a multidisciplinary care or approach to the management. I just want to highlight through this one or two case studies again. This is a boy with spontaneous trauma, difficulty, no other associated issues, but had oral lesions, so there was difficulty in feeding. So if you see this is a case of dystrophic EB, and here if you see the eyes, I don't know if it's very clear, but there is opacity coming in the periphery of the cornea. This is an example of limbal stem cell deficiency. Okay. Now, luckily in this child, there is no fusion of the digits yet. So early intervention using, these kind of bandages, separating the digits so that they don't stick together. That is another important thing to note in dystrophic EB. So you don't bandage them together. You separate them out and then bandage them. And of course, bringing in the dietitian early and the pediatrician early, we helped in avoiding even gastrostomy. But in this case, after this case, we started bringing in the ophthalmologist early because of the presence of limbal stem cell deficiency. This is another child who needed circumcision and a G2 placement because he was not growing at all. And in fact, we did both the surgeries together under one anesthesia. So the two interventions, feeding, gastrostomy, and circumcision, done all at one time surgery. And the effect is, you see this child who could even barely stand at the age of 3, you see him here. Okay, so that is the advantage of having a multidisciplinary approach. Now, because our country is so huge and I was living in Bangalore and the whole work was only in Bangalore, but I cannot restrict care only to patients who come to Bangalore. So we tried to reach out to the various other districts of Karnataka, for which we were thankfully given funding from an organization called EB-CARP. I'm very much indebted to them. And so what we did was, again, the focus was on care and support and diagnosis. So we reached out to different areas of the state through telehealth. And this all happened during the pandemic. And these are some of the figures of how many we have seen so far. Most important is, this is just 5 patients or 6 patients that we saw. If you look at the blue, that is prior to enrolling, the cost that is involved prior to enrolling into our program, and the reduction in cost after enrolling into our program. So there is a substantial reduction in the cost. And at the same time, it alleviates unnecessary anxiety among the parents, because they are given a direction on how they can manage this problem. The problem will persist throughout life because this is a genetic condition. But what we can do is improve their quality of life as long as they are alive. Now, what's the social angle to this? We build in support groups. So each patient helps the other patient and in tackling the problem. So in 2018, we had a conference, patient conference, that helps. And then, of course, all of this requires money. For every single thing requires money. So you use several platforms for sourcing. That means you raise funds using different online platforms. Now, before I end, I want to talk about the all of this, what I spoke just now is supportive care, which is the most important care aspect in care, even till today. But there have been advances in several approaches to therapeutics involving genetic diseases. Skin is a very difficult organ to grow. It is very difficult to model the skin, but there have been studies there where they are doing 3D skin modeling, and that has resulted in several advances. Initially, it was cell-based therapies where they did stem cell transplants to some of the dystrophic EB patients, but that had a lot of mortality. Fibroblasts were generated using patients' fibroblasts and injected into the wounds so that the the fibroblast helps in wound healing. But then this had to be repeated injections, which is cumbersome in pediatric age groups. So that led to more definitive approaches like gene therapy. And of these, there are two of these which have been approved by the FDA, US FDA. BVEC is ideally not a gene therapy, but what they have done is they have used HSV, that is herpes simplex virus, as a vector to grow normal collagen 7. And that is formulated as a syringe, but not given as an injection, but put as drops on the wound. So you mark, like how you do Botox injections, you mark that wound one by one, like a grid of 1 centimeter apart, and put a drop of that onto the wounds. And it is done once a week. But the problem to this is each syringe costs $25,000, which is practically impossible without insurance to do this. Even if they do it, there are other issues with this. You can use the syringe only once, and it cannot cover all the areas of the body. And it also does not treat the systemic complications. The only thing that treats the systemic complications like the esophageal strictures, the mitten hand deformities is your stem cell transplant. But that again has its own side effects. So now what they have done is they have tried to do what is called as autologous cell sheet based gene therapy. That means if I'm a patient, they take the skin from me, they take the fibroblasts or the keratinocytes. Fibroblasts are easier to grow. So the fibroblasts, they are converted to pluripotent stem cells. That is called as induced pluripotent stem cells, that is iPSCs. Now what they do is they correct the iPSCs of the genetic defect, then convert the iPSCs back to keratinocytes. You know from MBBS knowledge that pluripotent stem cells can be converted to any structure in our body. So with that scientific background, they first convert it to pluripotent stem cells, correct the defect, convert it back to keratinocytes, and grow them as sheets of skin, which can be transplanted onto the wounds. That supposedly helps in faster wound healing, one. And two, it might also reduce the chances of blistering because of the innate production of collagen 7 from the corrected skin substitute. Well, not substitute, corrected skin itself. I hope it is, I'm explaining in a very, very simple terms. That is this Ziva skin is the name of the product, and that is just approved probably about 2-3 months ago in 2025. I'd like to end my presentation by acknowledging our nurse, who is Silji. She has been the backbone of the entire EB program. And the team, which consisted of Dr. Subbarao, Dr. Jyoti, Srimati, Dr. Raj, uh, Pallavi, and Shrikant, who is a gastroenterologist, and Gurudatta, he was a scientist. This is him. Now Manoj and Dr. Divya both came in as dermatologists when we started the project in 2020. Although the work was going on before that also, but then the funding for a structured care came in with the pandemic. I'd like to also thank Dr. Aruni Namdar and Dr. Asha Kubba for mentoring me. They have silently done a lot of work. And of course, Debra International, Department of Biotechnology, Government of India, Government of Karnataka, and EB-CARP, that is Epidermolysis Bullosa Research Partnership, for their funding. And now, even though I'm not here, I'm very, very fortunate and thankful that Dr. Divya and Dr. Manoj are carrying the work forward. And in fact, the next step is we want to make it nationwide. This whole thing was focused only on Karnataka, but we still took patients from outside of Karnataka. We have built relationships with the dermatologists across, and we would like to see that this scales up to pan India. And above all, the most important is the patients who teach us forever. Thank you.
Thank you, Dr. Ravi, for your lucid presentation. I think epidermolysis bullosa is difficult, both for postgraduate students as well as the practitioners, but you have made it very simple and simplified method of approach to epidermolysis bullosa. Whatever it may be, as you have stressed, it is the teamwork that gives a lot to the understanding as well as management of epidermolysis bullosa. And with your team, you have exemplified that in a very beautiful manner. And I think all the growing dermatologists, they should take a lead from you. They have to develop a multidisciplinary team approach for various diseases, not only in epidermolysis bullosa, everywhere. Yes. For example, toxic epidermolysis, and even psoriasis. We require a multidisciplinary team for managing all this. But the message is very, very clear, and you have emphasized everything. It's good that you have done it. I'm thankful to you, and it is a good lesson for the growing dermatologists pan-India. So
I think it's God's grace.
I express our gratitude to you on behalf of Eastwards Pharma, all the postgraduates who attended the webinar, as well as on behalf of myself. Thank you, Dr. Ravi.
Thank you, sir, and thank you for the opportunity that I got. And it is really, I really hope the dermatologists, the young budding dermatologists, can take some condition, whatever they feel, and there's so many like neurofibromatosis, ichthyosis, neurocutaneous disorders, so many are there like that, which require, and they're very, very neglected. So thank you.
Doctor.
Thank
Dr.
you
Shah.
so much.
Thank you, Doctor. Doctor, our East West Pharma is really proud to have such a wonderful speaker from has given the lucid presentation for the benefit of the PGs, Doctor. Thank you very much for arranging such a wonderful program continuously for the past 2 years. We extend our gratitude to the course director, Dr. Kertain sir, as well as our speaker, Dr. Ravi sir. And my request for PGs, you can avail the program's edited version in our East West Pharma people. You can get it. And for the please inform the forthcoming month's program also. So for the benefit of the PGs. And Research Pharma is always committed for the academic sessions. Thank you, Doctor. First, we extend our gratitude to the speaker as well as to the course director, Dr. Kertain sir. Thank you so much, Doctor.
Thank you.